We are moving right along, and this segment, View from the Top, we are very honored to have Dr. Elton Tinsley, who is a 25-year senior surgeon, with us this morning. He practiced general surgery and burn surgery before training in plastic and reconstructive surgery. He is also a certified wound care specialist. Dr. Tinsley has worked in the consulting business as a plastic surgeon for a hospital-based wound care center both in Illinois and Indiana, and he currently acts as a wound care advisor for a Chicago area medical management company as well as several skilled nursing facilities. He is the principal author of Healed and Home, a compassionate solution for states' healed and home nursing wound care protocol that expedites wound healing, reduces both the costs and the number of pressure ulcers in Illinois long-term care facilities. And he returns residents to their primary residence in very expedient time. The national rate for pressure ulcer development in long-term care facilities is almost 12%. In the Illinois facilities utilizing Dr. Tinsley's Healed and Home protocol, the rate has decreased to an astounding 3%. He is an accomplished researcher and has published several articles and a textbook chapter on wound healing. His Home and Healed protocol is currently being considered for legislation. Dr. Tinsley, welcome to the Wound Wire. How are you, sir?
Hey, and good morning. Thank you. I'm doing quite well, and yourself?
I am great. I appreciate you taking time out of what I'm sure is a very busy schedule to talk to us and spend a little time with us on the Wound Wire. You've got a very interesting background, and certainly I think that our audience is going to be very interested in hearing what you have to say. The first question I have for you is, can you explain some of the unique challenges to managing wounds, especially pressure ulcers, in the skilled nursing facility?
Thank you, Dr. Niezgoda. Actually, the biggest challenge, I mean, when you specifically refer to pressure wounds, the biggest challenge is actually prevention. However, your question was not about prevention. Your question was really about what do we do now that we have a wound, and what do we do specifically when we have a pressure wound. I think the biggest challenge currently to managing pressure wounds, I'd have to say, is coordinated care.
Okay.
All the skilled nursing facilities, you know, we call them SNFs these days.
Right.
All the skilled nursing facilities, they have a number of physicians, a number of admitting physicians, a number of referring physicians, and every single patient has a physician responsible for their care. However, every single physician is not equally qualified, trained, or aware of the advancements that have occurred in modern wound care. So you have this extraordinary spectrum of dressings that are ordered, orders and requests from a broad number of physicians with a broad number of backgrounds. So you lack that consistency at the physician level. Well, once you have confusion at the physician level, guess what happens at the nursing level? So, you know, the situation gets, amplified and multiplied. So I would say that's the greatest challenge, is getting everybody to coordinate and work from the same playbook together to provide what's called advanced modern wound care.
Well, you know, I know the obstacles are great. The obstacles are significant in wound care centers across the country, and I'm sure they're, as you suggested, amplified in SNFs and skilled nursing facilities. But do you believe that specialized care can, in fact, safely delivered in these facilities?
Oh, without question. You know, the fact that you and I are even having this conversation, I think that CMS or the feds, Medicare, Medicaid, are taking a serious look, because inefficiency results in extraordinary expense and extraordinary cost to the system. And this is one place where we can actually make a difference, and that's in the skilled nursing facility. By coordinating care, applying the advances in wound therapy actually in the nursing home, you reduce, readmissions to hospitals, you improve healing rates and outcomes, not to mention, the quality of life for the actual resident with the wound. So yes, I think it can be accomplished, and I think it will be accomplished. As a matter of fact, I think that myself and those listening and those interested in this particular topic should be acutely aware of the fact that we are in the process really of making history. Dr. Niezgoda, I'm not sure exactly how old you are, but I think everybody remembers the days when the emergency room was staffed, by, what do we call them back then? Any guy could work in the emergency room. But emergency medicine, the emergency medicine was not a real medical specialty. I think that wound care is going to become, if nothing else, at least a actual certifiable medical subspecialty, if not a specialty.
I couldn't agree with you more, and I believe that. And you're exactly right. We are in a state of transition, and I think we're moving in a very positive direction. Let's transition a little bit and share some of your observations on the regulatory and legal climate. We all know these are changing, and essentially on a day-to-day basis, we're hearing more regulatory changes, and with the new healthcare initiatives that are in place, I'm going to see certainly more of that. But give us some of your observations. What are the climates like in both the regulatory and legal climates, and give us some of your thoughts in that regard.
In general, this is a time of change. The good news is they're looking at skilled nursing facilities, long-term care facilities. They're looking at nursing homes. The legislators know quite what to do. That's actually good news. So for change, they're actually coming to us. I can't speak about the broad spectrum of healthcare in this country, but specifically with regard to the nursing homes. We actually have a legislative meeting scheduled in the near future to sit down with some state legislators and talk about how we can impact outcomes in their particular state. What's very interesting is that the knowledge and the information, not the cost, is what's going to make a difference. So what we're proposing is a protocol that reduces states' costs at no cost to the state. So they're very interested. So for once in medicine, something may actually trickle up and become legislation to the benefit of a particular medical program. Largely our legislators are lawyers. They're not doctors. So it's a lot they don't understand, and they're willing to concede to us in the nursing home community and ask us what's best, and let's apply that template across the entire state, for example, or perhaps even the entire country. I really believe we're in the midst of making history with regard to long-term care, skilled nursing facility, wound care.
Well, that's interesting. Speaking of the change, one of the things that I have recognized, and we've talked to that a little bit, is that the increased litigation potential related to wound care. We're seeing a lot of litigation related to wound care. And
the best thing you can do to mitigate litigation with regard to wounds is wound prevention. The national prevalence rate of facility-acquired wounds in this country is about 11.5% nationwide. Right. Our rate is 0 to 3%. All right,
fabulous.
Exactly, just by applying those simple principles, which are not expensive. The real value is in the information and the approach. Yes, there's a high litigation rate in spite of that in our region and throughout the country. And I think it's largely because of advertising and marketing and the reputation the nursing homes have earned over the years. And I'm not going to say deservedly or undeservedly. The fact of the matter is the level of regard and respect of nursing homes or the lack thereof is such that, people that litigate have found easy ways to get customers. That 2 a.m. commercial, is your loved one in a nursing home? That's where it starts, unfortunately. And what's really interesting is the overwhelming majority of complaints or lawsuits that I've reviewed for the parent company, the wound actually developed outside the nursing home. But nevertheless, the nursing home was held liable for the wound. So we instituted a few programs to kind of minimize that, so that something called an acknowledgement form, for example, is used so that the family and the resident acknowledge at admission, yes, this wound was present prior to arriving at the nursing home. A bigger concern to me is that if you couldn't take care of your grandmother or your loved one at home and they come to the nursing home, that should be a relationship that should not be adversarial, but should be supportive of one another. How the family nursing home became so adversarial, I'm really not sure. But that's a climate that hopefully through public relations and programs such as this, we can change that dynamic before the patient even arrives in the facility. Something we can do to improve the overall reputation of nursing homes. And I think one of the ways is getting better outcomes.
Yeah, no, I think that improved outcomes translates to improved care, or at least is perceived as being improved care, and that goes a long way into helping with that relationship. I think those observations are right on the mark. So, preventing and good protocols goes a long way in mitigating risk. But how about the tools to accomplish that? Do you utilize electronic wound care documentation, and if so, how important is the electronic wound care documentation to mitigating risk and liability?
we specifically talk about our algorithm, and the algorithm is either to the left of a chart request or to the right of a chart request. Once a chart request comes in, you pretty much got a lawsuit on your hands. So on the left of the chart request are all the things we can do to prevent there ever becoming a chart request. We have several programs in place to support the family. Nursing home residents typically don't sue; the families sue. Mm-hmm. So how do we foster, that relationship? People that like you don't sue you. People that don't like you are likely to sue you. So it starts with the relationship, customer service, as in any other business, and with regard specifically to wounds, is informal education. Informal meaning we're going to talk about the fact that your loved one has a wound, what our strategy is to manage a wound, and let the family engage and get involved. You'd be amazed sometimes the families actually have, they've Googled a few things and they want to help. Mm-hmm. But get the family engaged and act as a team, foster the relationship between the facility, the staff, and the family. That probably goes further than anything else with regard to reducing litigation in single facilities, the relationship with the family.
Well, Dr. Tinsley, our time is, we could spend an hour here talking. I've enjoyed our conversation, and I'm sure our audience has really appreciated your insights in the area of wound care, especially as it applies to the skilled nursing facilities. And I applaud your efforts. I applaud what you have done in this area, and clearly you've designated yourself as a leader in this area, and look forward to hearing more from you, and maybe come back and join us on another episode of The Wound Wire. I want to thank you for spending time with us and sharing your insights on A View from the Top. Dr. Tinsley, any last closing comments?
Yes, as much as possible, manage the patient in the nursing home.
Fabulous. Well, again, have a great day, and thanks again for joining us.
Thank you, Dr. Niezgoda.